Hello, everyone. Welcome to episode 87 of the Retina Channel podcast. My name is Dr. Kayvon Kushan. I'm your host, usually for this podcast, but today's host will be Dr. Wai-Ching Lam from the University of British Columbia. Yes, this is another special episode of the EyeNovation webinar series hosted by the Canadian Ophthalmological Society. And Dr. Lam in this episode moderates a recording and a webinar with Dr. Angie Fong from University of Hong Kong. Dr. Fong gave us a fantastic overview of the pachychoroidal disease spectrum in this lecture. She focused on central serous chorioretinopathy, pachychoroidal vasculopathy, and pathogenesis, clinical trials, and also emerging management strategies for these. I'm very thankful to Canadian Ophthalmological Society for hosting this webinar series. Also thankful to Dr. Fong for coming to the webinar, and also Dr. Wai-Ching Lam and other panelists on this webinar who all contributed to this recording and this educational endeavor, which was a collaboration between the Canadian Retina Society and Canadian Ophthalmological Society. Well, I really learned from this episode and Dr. Fong's lecture on pachychoroidal spectrum diseases, and I hope you enjoyed as well. This is Dr. Lam and Dr. Fong.
So welcome to the EyeNovation's this international webinar series for the ophthalmic expertise. And we are very honored to have Professor Angie Fong from University of Hong Kong be our main speakers. On top of that, I have the pleasure to have our panelists here, also Dr. Kayvon Kushan, who is the co-chair of the CBD for the CRS. In fact, Dr. Kushan is very much responsible for this webinar series for the retina group, and he actually moderated the very first session, so it's a great honor to have him joining us in this panel discussions. We also have Dr. Yan from the University of Toronto and Dr. Zaid Mambo from the University of British Columbia. And the title for tonight's webinar series is Unveiling the Pachychoroid Disease Spectrum, a deep dive into the central serous choroidopathy and polypoidal vasculopathy. And the objective of the presentations are to assess the evolutions and the current understanding of the pathogenesis of pachychoroid disease spectrum disorder, to integrate the diagnosis and management of central serous choroidopathy and polypoidal vasculopathy by analyzing some of the recent clinical trial and management strategies, and describe the incidence and risk factors for the pachychoroid disease spectrum progressions in a natural observation study that Dr. Fong, I think, has authorship in it, and it is coming up in the, I think, recent retina publications. A bit of introductions for Dr. Fong. I think it's very kind of a great honor to have her speaking on this topic, as we all probably know that pachychoroid disease is far more common in Asia. So it is wonderful to have someone from the Asian regions to speak on this topic. So Dr. Fong is a clinical associate professor from the University of Hong Kong. She graduated from the University of Hong Kong with distinctions in medicines and was the recipient of the gold medal in clinical medicine for being the top of her class. She completed her Master Public Health degree from the School of Public Health in Hong Kong U with distinctions. And in addition, she has done both surgical medical retina training under Professor Peter Storman in Belgium and at the Wills Eye Hospital in the United States. Her research interests include VR surgery, retinal imaging, macular and choroidal disease, artificial intelligence, and translational care. And quite recently, she was awarded 2 patents for her work on AI in OCT imaging in age-related macular degenerations. And she has co-authored textbook in OCT imaging in central serous choroidopathy. So she is the perfect expert on this topic. And in addition to her scholarly accomplishment, she has served near a decade as a council member in the Hong Kong Ophthalmological Society and is the treasurer of the Hong Kong VL Society. She also a director of the Hong Kong Women Doctor Associations. And she is an editorial member of the Hong Kong Journal of Ophthalmology and the editor-in-chief of the Eye Opener magazines, publications of the Hong Kong Ophthalmological Society. So I welcome the participant from Canada and international, and I'm going to hand it over to Dr. Fong to speak on tonight's topic.
Thank you, Professor Lam, for the very kind introduction. I would like to thank the Canadian Ophthalmological Society for this wonderful opportunity, and I'm very, very honored and very happy here to share a bit of my experience on pachychoroid diseases. And I hope that I will have a very wonderful discussion with the honorable panelists here, and it's wonderful to meet everyone. So thank you very much. And so without further ado, let's get started. I'd like to share the screen. So can everybody see the screen now? Yeah. Okay. So I'm going to talk about the pachychoroid disease spectrum now with a focus on the CSC and PCV. So I have no conflict of interest. So I'm going to divide the talk into 3 parts. First of all, we'll talk about the what constitutes the disease spectrum in pachychoroid disease, and also to understand about the pathogenesis of these PDS. And also the second part, I will delve into some updates on the disease diagnosis and management of 2 diseases, in particular CSC and PCV. And the last part, I will share a little bit about the work that I've done with Professor Jemmy in Singapore about the incidence and risk factors for the progression of PDS in a natural observation study in a cohort of Asian patients. So it's working now. So this is a review by Professor Jimmy that you can find some of the information that I presented here. If you have time, it's quite a good review. So definition. So what is meant by pachychoroid? Pachy means thick, and pachychoroid obviously means thick choroid. And it is first described by Dr. Wara and his group in 2013, which described 13 patients with a thick choroid associated with some RPE alterations they can see, and they share the same phenotypic characteristics with CSC, and he coined the term pachychoroid pigment epitheliopathy for these groups, and he used the term pachychoroid to describe the thick choroid. However, not all eyes with thick choroid present the same way, and it is now known that we have a group of related disease that have the same phenotypic characteristics, and those include uncomplicated pachychoroid pigment epitheliopathy, central serous chorioretinopathy, pachychoroid neovasculopathy, polypoidal choroidal vasculopathy, and peripapillary pachychoroid syndrome. And all these diseases are characterized by increased choroidal thickness, the presence of dilated vessels in the hallux layer, otherwise known as pachy vessels, choroidal vascular hyperpermeability, inner choroid attenuation, plus or minus RPE abnormalities. Some may have serous retinal detachment or retinal pigment epithelial detachment, and some may have choroidal neovascular complications. So what is the pathogenesis of all these group of disease? It is now known that all these diseases are all caused by choroidal venous congestion, somewhat similar to like a blocked sewage system leading to overflow of these like kitchen or like bathroom appliances with regurgitation of the blocked of the contents inside the pipes. So if we go back to the anatomy of the normal choroidal vasculature, we have three layers. The larger size vessels are called the Haller's layer. The medium-sized vessel is called the Sattler's layer, and they divide into smaller arterioles and venules, which enter perpendicularly into a layer of choriocapillaris, which is a layer of choriocapillaries next to, in close association with the Brooks membrane lying just beneath it. And for normal choroidal drainage, we can see these on fast OCT, you can see that these choroidal vessels, they drain over 4 quadrants into the ampullae and out of the eye through the sclera. And this is a normal OCT image of a normal thickness choroid, which is around, this is about 200 microns in thickness. And you can see that with wide field, ultra wide field ICG angiography, you can see that the drainage over the 4 quadrants is relatively equal. However, in pachychoroid diseases, you can see these asymmetry of the drainage of these choroidal vessels. Here you can see the asymmetry of the flow with reduced flow over the infranasal and supranasal quadrants with increased flow over the temporal quadrants. So with advances in the multimodal imaging nowadays, we can see more clearly the choroidal vasculature, and with ultra wide field ICGA here, you can see that besides the asymmetry in flow, we can see these dilated Pachy vessels. Usually the 4 quadrants, the drainage don't really overlap, and there's a watershed zone, but these pachychoroid vessels actually cross the watershed zone. And sometimes you can see the pulsatile filling of these vessels with blood flow going to and fro these vessels, indicating that there may be choroidal stasis with increased hydrostatic pressure leading to the engorgement of these veins, choroidal veins, leading to a remodeling of these choroidal vessels, and these Pachy vessels may represent as anastomosis between these engorged choroidal vessels to relieve the hydrostatic pressure. Another feature found in these group of diseases is choroidal hyperpermeability. You can see that in mid-phase ICG, there is these increased hypercyanescence and a floccoid shape here, and which extends, which persists into late phase. And if we do an fast OCT at the choriocapillaris layer, especially in chronic cases, we can see the atrophy of the choriocapillaris, and as well as the inner choroid. And also it is associated with the dilated Haller's layer, or the larger choroidal vessels beneath. So we shall go into a little bit about each of the diseases in the PDS spectrum. So what is meant by thickened choroid then? There is a wide variation in the normal choroidal thickness, ranging from 191 to 350 microns in studies. There's no set definition currently where a set point above which is abnormal. For our natural observation cohort, we used more than subfoveal thickness of more than 300 micron as a cutoff. For pachychoroid pigment epitheliopathy, as described by Dr. Wara and his colleagues, these are eyes with thickened choroid associated with RPE alterations on fundus autofluorescence. You can see here with stippling of hyper and hypoautofluorescence. However, there is no neurosensory detachment or RPE detachment in these cases. For central serous chorioretinopathy, it is well known and it was described many years ago. The characteristic is that there is neurosensory detachment of fluid under the retina, or sometimes intraretinal fluid as well. Also, some may have RPE detachment, and it's also associated with a thickened choroid. It usually is divided into acute stage or a more chronic or persistent stage. It has a high rate of natural resolution, usually especially the first, if it is the first time, then the fluid usually resolves in 3 to 6 months. However, it would be persistent if it persists more than 4 months. And if it resolves and then recurs later, and then it will be classified as a recurrent CSC. And if the patient has a lot of recurrence and chronic SRF, then it may result in a widespread RPE decompensation that we can see on FAF as gravitational tracts, and indicates a widespread RPE damage. And in these cases, sometimes we can see the advent of choroidal neovascularization as well on OCTA that we can see here. So these kind of vessels we call a pachychoroid neovascularization, and as I just mentioned before, with the remodeling of the hallux layer, and pachy vessels crossing the watershed zone, indicating increased hydrostatic pressure. Then sometimes the overlying inner choroid and also the outer retinal layers and the RPE becomes damaged and atrophied. And as the time goes on, it may also herald a neovascular membrane. And it can show up on the OCT angiogram as a branching network of neovascularization. And it can also be visible on ICG angiogram as well here. And usually the location of the pachychoroid neovascularization is usually over the pachy vessels and the dilated choroidal vessel layers. And this is another example, we can see that there is an RPE abnormality under the fovea here, an OCT angiogram. You can see the neovascularization in the outer retinal layer, and also in the choriocapillaris layer. And if we do an angio B scan, we can demonstrate flow within these neovascular network as well. Next is polypoidal choroidal vasculopathy, or aneurysmal type 1 macular neovascularization. It's first described by Dr. Iannuzzi in 1990, and is now understood to be a variant of type 1 macular neovascularization, and which is a sub-RPE neovascularization, and its characteristic is these end-terminal polypoidal or aneurysmal lesions. It is less common in Caucasians, but very common in Asians, and it is estimated that around 20 to up to 50% of of Asians suffering from neovascular AMD actually have PCV. And although it is found in drusen-associated neovascular AMD, it is also found in a range of other diseases, including pachychoroid disease spectrum. It is also found to be associated with angioid streaks, myopic staphylomas, etc. So it's not exclusive to just age-related macular degeneration. The gold standard of diagnosis of PCV is ICGA, which you can see some polypoidal lesions, such as here, associated with a branching neovascular network, or previously known as branching vascular network. So we move on to the next entity, peripapillary pachychoroid syndrome, which is a distinct entity with a thickened nasal macular choroid. You can see some atrophy in the peripapillary area. On FA, on late phase FA, you can see some leakage in the peripapillary area. And if we do an OCT angiogram to look at these peripapillary vessels, you can see that in the peripapillary area, there is increased flow in the choroidal vessels, and also in the chorioretinopathy PO veins that drains into the central retinal vein. It's also dilated. So it represents some anastomosis with the deeper choroidal vessels with the chorioretinopathy veins, attempting to alleviate some of the increased pressure by draining through the central retinal vein. So it is also another entity of the Pachychoroid disease spectrum, where in this particular entity, there is an increased hydrostatic pressure in veins, in choroidal veins around the optic disc area. So what causes the choroidal venous congestion in the first place? So some work has been done, and scleral thickening has been implicated. Imanaga, doctor and his colleagues have shown that there is the scleral thickness in CSC eyes is increased in these patients, and also increased scleral thickness is correlated to increased chorioluminal stromal ratio. Means that the lumen is relatively dilated in these patients with increased choroidal thickness, which corresponds to eyes with PDS. And Dr. Spade and his colleague also demonstrated the presence of fluid in the suprachoroidal area, which is between the boundary of the outer sacclar layer, the hallux layer in the choroidal vessels, and the junction between the choroid and the sclera. So you can see some loculated fluid in CSC eyes or eyes with PDS, which suggests that there is actually effusion of fluid from the choroidal veins into the space between the choroid and the sclera, and he names it a suprachoroidal effusion, and it's seen in a number of eyes with PDS. So he suggested that thickened sclera in these patients may impair the vortex vein drainage, and it leads to the decrease in outflow and increased hydrostatic pressure in the choroidal veins. But why doesn't all patients with these kind of abnormalities have PDS? So currently a two-hit theory is proposed, which means that you have to have an anatomic predisposition, such as thick sclera or asymmetric vortex vein drainage, short axial length. But you also have to have an inciting event, such as steroid use, some implicated abnormal sleep pattern, lack of sleep, or obstructive sleep apnea. Some may indicate, some have suggested the role of sex hormones, because this is a male predominant disease in CSC. So you have to have a two-hit theory leading to the overloading of the choroidal outflow system, leading to raised the choroidal venous pressure. So the eye reacts by having compensatory mechanisms, such as dilated choroidal veins, especially in the big vessels in the hallux layer. And if there is, it is chronic, then there is choroidal remodeling with the intervortex anastomosis in the form of Pachy vessels to try to dissipate raised venous pressure through drainage through other quadrants of the venous system. So if it is able to resolve this raised hydrostatic pressure, then there is stabilization and no further progression. However, if it doesn't work, then the eye decompensates and the whole vortex system becomes overloaded, and there will be generalized venous stasis and hyperpermeability of the choroid, such as we can see in the multimodal imaging of these PDS diseases. So then the eye goes into a vicious cycle if this increased pressure is not resolved, leading to choriocapillaris impairment, outer retinal damage, RPE dysfunction, and which is evidenced by the fundus autofluorescence changes that we can see in chronic CSC. And by this time, there would be visual impairment. And if there is, and time even goes further on later, then because of the damage in the outer retina as well as the RPE, neovascular complications such as PNV and PCV may occur. So up till now, so we've kind of gone through the pathogenesis of PDS and the various disease entity of the PDS. So Professor Lam, shall I go on? Keep going? Is that okay?
Yeah, you're good. Please go on.
Okay, next. Okay, great. Okay, so we'll move on to the second part now about the disease updates in the disease and diagnosis of CSC and PCV. So as I've mentioned before, we have better multimodal imaging now, and studies have, but however, until now, there's no good way of or standardized way of classifying CSC. And Dr. Jablani and his group has proposed a multimodal imaging of CSC based on multimodal imaging, basically. So he described that he proposed to divide CSC into simple or complex CSC, or depending on RP alteration area. If it is less than 2, this diameter is simple. If it's more than that, it's complex. And if it's first episode, they classify it as primary. If it's if it resolved and then recur again, they call it recurrent. And if the absence of SRF, they call it resolved. And they mentioned that if it's more than 6 months, then they call it persistent CSC. I should also comment on whether there is outer retinal atrophy or in complex cases in intraretinal fluid, and the presence or absence of choroidal neovascularization should also be mentioned. And there is another type called atypical CSC, which includes some bullous variants and or those associated with other retinal diseases for RPE10. So another markers associated with CSC and PDS is the presence of pachychoroid, and this is, I will talk a little bit more on this in the coming slides. However, the significance is that it is a strong predictor of progression in chronic CSC and PCV, and also may herald the presence of choroidal neovascularization. So this is an important sign to look for in patients with CSC. And this differs from the soft drusen in age-related macular degeneration, where it's usually a mottled appearance with a decreasing in density starting from the middle going outwards. So it's not uniform. And usually it's larger, and the choroid is usually thinned instead of thick. And so this is usually associated with age-related, the kind of drusen-driven age-related macular degeneration that we're familiar with. And on OCT, we can see the so-called double layer sign. We can see the separation of the RPE from the underlying Bruch's membrane. And this is to be differentiated from a pseudodrusen, which is yellow-white, and it's uniformly round and punctate interlacing network, and it's usually a bit smaller, from 125 to 250 micron, and the location is actually above the RPE instead of between the RPE and the Bruch's membrane, which it shows up nicely here on this OCT scan. Which is different from the pachychoroid that is noted in the Pachychoroid disease spectrum. And for these pachychoroid, usually they have an irregular contour, and it's uniform basically they're uniform in appearance, and also they can appear as solitary, clustered, isolated, or scattered deposit with a well-defined boundary. And for these cases, it is also found in the sub-RPE layer and between the RPE and the Brooks membrane. And usually it's it's a bit larger, it's more than 125 microns. And underneath you can see usually a thickened choroid. So this is actually distinct from the other two types of drusen, and it is something to look out for when we're treating patients with CSC or other pachychoroid diseases. Another biomarker is the shallow irregular RPE elevation or SIRE, which is a subgroup of the double layer sign. So double layer sign is the separation of the RPE and the Brooks membrane, as we can see here, okay, with heterogeneous internal heterogeneous internal reflectivity. And for SIRE, it is defined as DLS, that is more than 1,000 micron in length and less than 100 micron in height. So it's a subgroup of double layer sign. And these signs are strongly associated with type 1 or sub-RPE neovascularization. And usually in pachychoroid diseases, the SIRE or double layer sign is located right above the dilated choroidal vessels, as we can see here. You can see the dilated Haller's vessel, and above which there is the SIRE. And then if we do an OCTA in this area, often you can actually see these branching neovascular networks or pachychoroid neovascularization. So this is something that we should look for in PDS diseases as well. Sometimes if you can see these double layer sign, and in CSC, especially with fluid, sometimes it's difficult to differentiate whether the fluid's actually from the PNB or from the CSC. So in these patients, it's harder to treat. And in addition to the treatment of the CSC, sometimes we have to consider anti-VEGF because the fluid may be from the PNB as well. So combined therapy may be indicated in resistant cases. So moving on to treatment, okay, and for the acute phase, there's a high rate of resolution, so it is okay to observe a spontaneous resolution. However, once it goes to a persistent or chronic or recurrent stage, usually treatment is indicated. And in the recent report by AAO, they indicated two level 1 studies. There was only 2 level 1 studies for the acute CS, and it's only for acute CSCR, where it is for the PDT. And one is by Dr. Chen Wan in 2008, where he used half-dose PDT for CSC, and it is effective in resolving the fluid. And recently, in 2015, another RCT was performed to evaluate whether 1/3 dose is as effective, but it was found that half dose is more effective than 30% dose in resolving SRF and CSCR. And And also another note is that half fluents can also be used, but the level 1 evidence, the trials was half dose was used, half dose PDT was used. And what about laser-based therapy? High density subthreshold micropulse laser was evaluated in a PLACE trial, and it was an 810 micron diode laser was used. However, in this trial, half-dose PDT was found to be superior in terms of SRF resolution, best corrected visual acuity, and microperimetry. However, there are more recent studies using the 577 micron yellow laser beam, and they have reported better results. Dr. Breland and his group in Wai-Ching, Hong Kong has published a randomized control trial with this, and where they used micropulse laser of a spot size of 200 milliliters with a power of around 340 to 400 millivolts with a duration of 200 milliseconds with 5% duty cycle, and they covered the area of subretinal fluid with this, and they compared with the half-dose PDD group. At 1 month, there was lower rate of SRF resolution. However, at 12 months, both groups reached a comparable rate of SRF resolution. So there's evidence that the 577 yellow laser subthreshold micropulse laser actually works in PDT. But that half-dose PDT still had a faster recovery and SRF resolution than the laser. So what about oroeplerenone? So in the VICTORY trial, it was evaluated for a group of patients taking 25 to 50 milligrams of oroeplerenone per day for up to 12 months. And however, it was not shown to be superior to placebo. And because of the possibility of side effects such as hyperkalemia, the authors did not recommend the oral medication for the patients with CSCR. So moving on to PCV, we know that the gold standard for diagnosis of PCV is ICG. However, ICG is often invasive and is also not readily available in all centers. So in the Asia Pacific Ocular Imaging Society, we've come up with a criteria for non-ICG diagnosis for PCV. And they've evaluated nine signs or biomarkers, and they have classified it into 3 major and 4 minor criteria. One is the sharp peaked PED, as you can see here. It's almost like a thumb-like protrusion with an inverted V configuration. And it has to be very sharp, like more than 70 degrees on at least one side, and to be called a peak PED. And the second major criteria is that within the PED, you can see this ring-like structure inside PED. And the third major criteria is on the on-fast OCT. You can see a complex RPE elevation with hyperreflective branching vascular network connecting with multiple PEDs. So if you have all 3 criteria, then the accuracy of detecting PCV is more than 85%. And now you have more minor criteria, such as multilobar PED here. You can see this notch here indicating that is a multilobar PED. The double layer sign, as I've discussed just now, this undulating RPE with heterogeneous internal reflectivity that represents the separation of the RPE with the underlying Bruch's membrane. And also thickened choroid with dilated hallux vessel, as demonstrated here in this picture, with thickened choroid, as well as this very dilated choroidal hallux layer vessel. And lastly, it is on the fundus photo or clinical examination, can see these orange nodules. So as I mentioned, as I mentioned before, the accuracy of diagnosing PCV is 90% if you have all 3 major criteria. And however, not all centers have the on-fast OCT. So even if you have any 2 major criteria, including the sub-RPE ring-like lesion and sharp PED, you have an accuracy of more than 80% in diagnosing PCV. They have also suggested a new nomenclature for describing PCV because polyp is not a very good term, and same as aneurysm, because these lesions in PCV are neither polyp, as in fleshy polyp, nor are they actual aneurysm. So they would recommend to call these lesions polypoidal lesion. And for the network, previously it was called branching vascular network, but instead of normal vascular network, it's actually neovascularization. So they suggested calling them branching neovascular network, and which are the two diagnostic criteria for PCV. And we should go through the clinical trials for the treatment of PCV. So the options are anti-VEGF monotherapy or in combination with photodynamic therapy. Argon laser, traditional argon laser may have a role, but it's only limited to extrafoveal PCV or very obvious nodules. For the Everest-2 is a trial to compare the initial therapy with ranibizumab plus PRN or plus ranibizumab therapy in a PRN schedule versus combination of ranibizumab plus PDT as initial therapy. And at 24 months, the visual gain was that the combination therapy fared better with a higher rate of polyp regression as also reduced disease activity. And this effect is continued in a recent study to report the 6-year outcome of the Everest-2 trial, and this superiority is maintained at 6 years. And there is for the combination group, they required reduced number of anti-VEGF injection, and there is greater reduction in central retinal thickness as well as greater subretinal fluid resolution. So there may be some role in the actual choroidal remodeling with the PDT in the combination group that led to the subsequent reduced requirement of treatment later on. So the PLANET study is a non-inferiority trial comparing aflibercept monotherapy in a fixed dosing schedule versus aflibercept plus rescue PDT. And they found that only very few, a minority of patients needed rescue PDT in the primary endpoint. And the vision gains are similar in both groups, and the same was found for polyp regression rates. And they found that there was no added benefit for PDT with PDT for those meeting rescue PDT criteria. However, caveat is that only a small number of patients met the rescue criteria for PDT, and therefore the actual patients in this trial receiving PDT was very small. And that it differs from the Everest in terms of not only the anti-VEGF agent, and also the group was not compared because the combination group, not all patients in the combination group received PDT as well, and they only received this rescue PDT therapy. So direct comparison of these two as a initial therapy could not be performed, because this is, and the study design is that this is a rescue therapy for PDT in this trial. So what about faricimab? And in the FDD randomized control in the pivotal trial in Tenea and Lucerne, the subgroup was too small to have any meaningful results. However, the Asian trial of Salween is going on, and to evaluate the effect of faricimab on PCV, and 16-week was for the 16-week interim results. They found a positive effect with 80% of the patient being fluid free, with 50% of them having polyp regression. A recent meta-analysis of 7 studies done in Japan and Singapore resonates the same similar results, meaning that after 3 loading dose, they had a meaningful decrease, and they had stable best corrected visual acuity with decreased central retinal thickness, and also they found a polyp regression rate of about 50%. And they also found a good response for patients switching over from other anti-VEGF agents with about 50% 50 to 60% fluid reduction, and 21% of the switch over patients can have extended dosing interval. For brolucizumab in the Hawk and Harriet trial, they reported robust BCVA gains with PCV patients treated with brolucizumab. Interestingly, they demonstrated superior outcomes to aflibercept with a 70% fluid-free patients and 60% resolution of the RPED, and 68% maintained Q12-week dosing until 96 weeks. And they reported a higher polyp closure rate, up to 80% versus only 50% for aflibercept. However, we all know that there are incidences of intraocular inflammation, especially retinal vasculitis that can result in severe visual loss. So careful risk-benefit analysis must be made before we decide whether to give brolucizumab for patients with PCV. I wouldn't recommend it for treatment-naive patients. However, with patients with very recurrent, resistant type of PCV, especially those with very large PEDs, and patients are losing vision despite very, very frequent injections of other anti-VEGF agents, then their brolucizumab may have a role in these cases. So what about high dose aflibercept, 8 milligrams? In the PULSAR PCV subgroup, about 139 patients, they randomized it 1 to 2 milligrams Q8 versus 8 milligram Q12 versus 8 milligram Q16 weeks. And they reported similar gains. And even in this PCV subgroup, 80% maintained at 12 or 16-week dosing, and they reported reduced area of polypoidal lesion as well. So we know that all these anti-VEGF agents work. And what about these? What about the regimen? So in a treatment recommendation by the Asia Pacific Vitreoretinal Society recently, it was recommended that treat and extend is the recommended regimen with reloading dose to extend by 2 to 4 weeks up to 12 to 16 weeks to shorten the interval if there is disease activity. And as we know from the Altair study, that minimal subretinal fluid may sometimes be tolerated. And compared with a non-PCV type of AMD, we know that PCV is could be less responsive, especially with those with especially the branching neovascular network. And so besides fluid, sometimes we need to look at polyp closure as a marker as well for disease progression, because a polyp non-closure may lead to a higher rate of disease recurrence and disease activity, and sometimes it may result with massive subretinal hemorrhages that could cause severe loss of vision as well. So Dr. Teo and his colleague has recently done a randomized control trial where he did another ICG angiogram about 3 months after the initial therapy, and repeated after the initial loading dose, with 3 anti-VEGF. And if he found persistent polyp, then he would inject another 3 loading dose. That means within prolonged induction phase of the anti-VEGF therapy. And he found that with this more intense induction phase therapy of anti-VEGF for PCV, the outcomes are similar to those treated with a fixed dose of aflibercept bi-monthly dosing over 24 weeks. So this probably indicates that for patients with PCV with non-regressing polyps, probably we need a more intense therapy for them, especially in the initial induction stages. So what about monitoring? So we all know that sometimes ICGA may not be available in all centers and it's still invasive. So we have recently a study has been published to report a non-ICGA criteria for PCVs with suboptimal response. So these are the markers to look for. We are considering more intense therapy, which includes which includes the peaked PED, here orange nodules, and as well as the subretinal sub-RPE ring-like lesion. So if we have all these sharp PED, sub-RPE ring-like lesion, and orange nodule seen, then you have a 85% accuracy of detecting the persistence polyp in these suboptimal responders, and it is an indication for further therapy or even combined therapy with PDT in these patients. So we move on to the last section. I will try to move, I'll just spend probably like 5 minutes on this because I think we're a little bit short on time. So I did a natural observation study, as I mentioned before, with SNAC, looking at a cohort about 200 eyes and this patient with PDS, and we looked at whether a natural observation about the rate and of progression of these diseases. So we did multimodal imaging for these patients. We looked for OCT features of the features that I've discussed previously. And at baseline, about 21% had uncomplicated pachychoroid, 45% had PPE, 23% have CSC. And interestingly, at baseline, originally cases diagnosed with CSC and PPE, some of them already harbored neovascularization, 2 out of 84 in PPE and 18 out of 59 had MNV, and they had to be reclassified. So even for patients where in clinically they did not have any, that could not detect any overt neovascularization, but if we do an OCT angiogram, some of them has already harbored a non-exudative neovascularization there. So progression at 1 year, we found 14 eyes that have progressed. 1 eye from uncomplicated pachychoroid to PPE, 5 of them from PPE to CSCR, 5 of them from PPE to PNV, and 3 of them from CSC to PNV. And luckily for the exudative, the PNVs that has progressed, they are either non-exudative, that is found in OCT angiogram, or even for the exudative one, they are low activity type, and they've responded very well with only a few injections of anti-VEGF, and they stabilized. So of the risk factors we assessed associated with the progression development of PNV, we found that age and smoking are conferred a higher risk, but also the only ocular risk factor that we found is the presence of SIRE. And we found that the presence of this sign is strongly associated with risk of progression and also the risk of neovascularization in cases with pachychoroid disease. So in cases with PDS you're looking after, I think it is important to look for the sign on OCT. And if you find that, then it indicates that you need to have a closer monitoring for these patients for the development of neovascular complications. So we propose that instead of a linear progression going from uncomplicated choroid, PPE, CSC, and then PNV or PCV, we now pose that is probably the neovascularization could be a complication from the pachychoroid disease spectrum going from uncomplicated choroid to CSC. And the risk factors besides genetics, age and smoking, or other risk factors, then for these eyes, then for some of these eyes, then it would develop pachychoroid neovascularization or polypoidal choroidal vasculopathy. So in summary, I think PDS is a spectrum of disease with thickened choroid with a range of different manifestations, and the pathogenesis appears to be from the choroidal congestion and increased hydrostatic pressure there. We need to look for pachydrusen and Sire as biomarkers for progression of neovascular complications. For Asia, or at least from Hong Kong, half-dose PDT is the mainstay for chronic CSC or recurrent CSC. We now are shifting towards non-ICG multimodal imaging for the diagnosis and monitoring for PCV. And anti-VEGF monotherapy works just as well as PDT in some studies, but for patients with polyp non-regression, I think PDT may have a role, or for anti-VEGF therapy, they need to be more intense for these group of patients. For a natural observation study, we noted that short-term or at least 1 year progression rate is low, and those with PNV had good response to anti-VEGF therapy, and old age, smoking, presence of Sire is associated with higher rates of neovascular complications. So that's all I have to share. And should I, Professor Lam, should we move on to the discussion part?
Yes, thank you. No, thank you for that such an in-depth presentations on the pachychoroid disease spectrum. I mean, this topic is huge, so it is difficult to really do that in such a short time, and I think you have done a very comprehensive review. For people online, you can type in your questions on the chat, and we open up the questions to the panelists. Maybe I'll just start off first, and then and let the rest of the people ask questions also. Pachychoroid sometimes are seen in asymptomatic patients, and we do our OCT. Should we be concerned? Right, we see that.
So yeah, uncomplicated choroid, I think without PPE, without any other abnormalities, the progression rate, as I mentioned, is low. And you can see that only one patient progressed in the uncomplicated pachychoroid spectrum to PPE. So I don't think it's much of a concern. I think the progression rate is low. And you can see that no uncomplicated choroid suddenly developed neovascularization or any other severe visual threatening complications. So I think it would be okay for us to monitor it, but it will be important to do multimodal imaging for these patients because, as I have mentioned before, some patients actually have abnormalities that may not be so obvious in clinical examinations, that would only show up, say, in fundus autofluorescence or even OCT angiogram.
From the chat, any role for spironolactone?
Yeah, so we don't use spironolactone or eplerenone in Hong Kong. In fact, all our patients with CSC, we treat either with half-dose PDT or with yellow laser, sub-threshold micropulse. We don't have the I don't think the 810 micron laser works. I think the 577 yellow laser works better.
Thanks. Dr. Kushan?
Thank you, Professor Fong. It's a fantastic review of pachychoroid disease. I learned a lot, and thank you so much. I was wondering about the risk factors. You mentioned the anatomical risk factors, a thick sclera, thick choroid, but the modifiable risk factors like steroid use or smoking you mentioned, what's the pathogenesis of someone being what we call type A or smoker causing this? Do we know any about the background, the physiology and pathology, what causes that?
Yeah, it's still not very elucidated, but then like we definitely know that mineralocorticoid or steroid plays a role. And I think because of like type A personality, you have a higher endogenous corticosteroid and also male. We don't know about the role of male hormones, but definitely it has some role in the regulation of the probably the vessel diameter or the autoregulation of the vessels in the choroid, and this regulation of that may predispose these patients to the increase in the hydrostatic pressure of the overload of the venous system. And that's why we propose the two-hit theory. So it's not just steroids. It's probably the patients are already anatomically predisposed, plus that there is an inciting event that causes the overloading of this and cause disease presentation.
Okay, I don't know who's hands first, but I'll get Dr. Mamo and then Dr. Yan. Dr. Mamo, go ahead.
Thank you. Great talk. Thank you so much. Very comprehensive. I was going to say, for the polyp closure, maybe it's a nuance, but do you think the polyp closure is different with anti-VEGF versus PDT? Is one more permanent and long-lasting, and one maybe just more of a temporary thing just because of the effect of the medication? So I see the kind of the trials talk about them as outcomes, but are they truly the same if you are doing PDT and then one is just using anti-VEGF?
In my experience, yes, definitely. For PDT, they definitely actually help with the complete regression of the polyp, as in like you do not see them at all on ICG, and it definitely helps in terms of disease recurrence in the long term. In my experience, whereas for anti-VEGF, I see that it reduces disease activity, as in they do not exude or leak as much. And also you need quite frequent anti-VEGF therapies, at least for anti-VEGF. I'm pretty sure for the longer acting agents, I'll be interested to know like how well they do with complete regression of the polyp. But I say that anti-VEGF do suppress the activity pretty well, but not too much on the complete polyp regression rate. But that is to be balanced because and if you do a very wide kind of a big area of PDT, and later on there will be macular atrophy, and that could affect the visual acuity as well. So it has to be carefully balanced.
Thank you.
Dr. Yan?
So Dr. Fong, that was a great presentation. So you covered a lot of really sort of black box in ophthalmology, pachychoroid spectrum disease, the various drusins that you touched on, especially pachychoroids and so on. In regards to CSR, is sleep apnea test warranted for patients with CSR, given that 30 to 50% CSR patients sleep apnea?
Yeah, so sleep has been implicated and also studied in the pathogenesis of CSCS, seems to be related. And there are some trials, trying melatonin or like sleep cycles, sleep studies for these patients, but they do not have a conclusive, evidence to say that, this sleep has, definite relation with the CSC. So same as mineralocorticoid and steroid, I think that it has a role, but I don't think this is the only causative factor for the development of CSCR. So as again, I think it has to have a multi-hit kind of theory, or like have to have an anatomical predisposition or genetic predisposition with this event combined to have the development of the disease, I think.
From online, how soon would you treat chronic CSC, and would you still treat if fluid is persists more than 1 year?
For the first presentation, usually I will allow around 6 to 8 weeks. I mean, sometimes up to 3 months, but usually I won't wait that long. If it's still persistent, usually I would recommend half dose PDT for this group. And the second question is if it persists for more than 1 year.
Yeah.
Yes. Oh, absolutely. I would definitely treat these cases. Yes, I would treat for recurrent, for chronic cases, for chronic recurrent cases. Yes, I would treat.
You did mention about use of anti-VEGF. From online, the question come up again, like what's the role and how effective it
So
is?
unless they develop, yes, so if they develop neovascular complications, if I see, neovascular PNV networks or fluid from that, then I would also consider combination therapy. But as I've mentioned in the talk, that sometimes in chronic CSC, it is difficult to know whether the fluid from that we see is actually from the CSC itself or it's from the PNV. So in these very resistant cases, maybe there is a role of combination therapy with anti-VEGF plus PDT.
Another question on the net. If CSC and PCV are both derived from venous congestions, do we know what led to their diverging phenotypes?
Sorry, CSC and PNV or PCV?
Sorry, PCV. So both CSR and PCV are from venous congestions, but they seems to present differently at the end. Like one has polypoidal lesions, the other one is just leakage. Then why would they be different?
Yeah, so the exact mechanism is still not very clearly understood at the moment, but I think PCV, besides, as I mentioned at the top, PCV does not occur only in the pachychoroid spectrum. It is also found in other diseases, such as drusen-driven AMD, with a thin choroid in these cases, and other like myopic maculopathy, angioid streak. These ones are also found. So I think that PCV is actually a neovascular complication that can occur, that can arise from from various diseases, one of which is pachychoroid disease spectrum, such as CSC. So instead of a continual spectrum going from CSC to PNV to PCV, PNV and PCV could represent neovascular complications arising from CSC.
I get the permission to push the webinar for a few more minutes. So questions, how you distinguished pachychoroid versus drusen in a pachychoroid? Like when you look at drusen, sometimes coexist in a patient with pachychoroid, although it's not that frequent because that's how you may distinguish that from AMD. But you also describe pachychoroid. So, what also the etiology for the pachychoroids?
Yeah, so I think it's quite difficult actually even for me. But as I mentioned in the few slides in the talk, that it's usually differs from the hard drusen, and the appearance is different. So it's the soft drusen is usually more mottled in appearance, less uniform, going in the density goes from more dense in the center outwards and less dense outwards, but a pachychoroid is actually more uniform, and also obviously and on OCT that the choroid is thickened, and unlike the thin choroid in the typical age-related macular degeneration. There's a good paper on talking on just pachychoroid, and if you're interested, I can send it out later on, and they have got a detailed description of what pachychoroid looks like. I've taken a few diagrams of that in my talk, but you can look into that if you have time. Yeah.
Thanks. Dr. Yang?
So I have a question just for our ophthalmology colleagues. So not all subretinal fluid with either SIRE or double layer sign or PED or CSR. So often they're best retinopathies, sick RPE, secondary AMDs. So what are your sort of your sort of approach to looking at this and identify this is a CSR as opposed to its differentials, and what are your top differentials when you see this, such that so people have an approach when they see subretinal fluid with PED, because that's usually our first sort of diagnosis is a CSR when we see fluid.
Sorry, I couldn't hear very clearly your question. Is that like if you see was the question if you
My question
see subretinal fluid?
Yeah,
Was it
just a
CSC
differential,
or AMD? Is it?
yeah, your top differential diagnosis for CSR, and to rule out some of the other sort of diagnosis that shouldn't be missed.
Yeah, so there are a lot of differential diagnosis for fluid, under CSR. Main differential obviously would be an AMD. Then I of course have to look at the patient profile, whether it's young patient or old patient, and whether there are other abnormalities seen in other imaging, for example, on FAF, and OCT. I would definitely do multimodal imaging for these patients, not just the OCT scan, including FAF. If I see like the typical gravitational tracts or hypo or autofluorescence, and of course it will be more pointing towards CSC. Then I would look at I would use EDI OCT or SSOCT if you have it, and look at the choroidal thickness, and also if possible, can take a look at when you use OCT-A to look for any neovascularization. If there is, then it's more pointing towards a kind of could be AMD or neovascular complications. Yeah.
That's a lot of time. So one last question from the online. In places where PDT is not available, and what would you recommend as the first line of treatment? Anti-VEGF or other alternative? Yeah.
Yeah, so for CSC, the protocol for treatment would be for acute ones, I would observe for natural regression. If it's not regressing, it goes into persistent, then I would try the 577 yellow micropulse laser. And for the PCV, then I would use anti-VEGF monotherapy, but I would do a more intense type of injection. I'll use as I mentioned before, the ICG, either ICGA guided or non-ICG, a biomarker guided polyp regression as my guide to see how often or how long I should inject it. But I will be looking at a longer duration and a shorter frequency of more intense frequency of injection if I do monotherapy.
Thank you. So I know there's still more questions, but I have to close the discussions. Thank you, Dr. Fong, for such a comprehensive review. It's tough for you to do this in such a limited amount of time, and but you did a wonderful job. And I think it was a great review for everybody to kind of understand this challenging management of pachychoroid disease spectrum. I also like to thank the panelists for taking part and sharing their questions with the group. And in closing, I want to get Dr. Kushan to give some kind of update on the webinar that we are having coming up in the next couple months.
Sure, Dr. Lam. Thank you very much. We're going to continue this fantastic presentation with the same theme. Next month on April 10th, we're going to have Professor Robin Geimer from University of Melbourne, Australia. She'll be talking about different variations of AMD. She'll be talking about the Sire sign that Dr. Fong talked about. So that should be a fantastic presentation as well. And in May, we'll have Dr. Ioannis Dimopoulos from University of Ottawa talking to us about different approaches and different modalities in inherited retinal diseases. So I look forward to that presentation, and hopefully everyone can join us as well. And thank you, Dr. Lam, Dr. Fong.
Well, thanks very much for everybody. And thank you, Dr. Fong, particularly you're very early in the morning, so from Asia joining us. Thank you.
No, thank you. Thank you so much for inviting me. It was my pleasure and honor to be here, to be sharing with you all. Thank you so much.
All right. Good night and good day.
Thank you. Bye-bye.
Bye.
Bye. Well, folks, this wraps up episode 87 of the Retina Channel podcast, which was a reproduction of the Canadian Ophthalmological Society EyeNovation webinar series hosted by Dr. Lam, and we had wonderful panelists on board as well, and of course our fantastic guest speaker, Dr. Angie Fong from University of Hong Kong. I want to thank Dr. Fong, Dr. Lam, and the panelists for contributing to this webinar series, and also a special thanks to COS for hosting the EyeNovation and also providing scaffold for CRS to contribute and collaborate with COS. On that note, our next episode will also be an EyeNovation webinar series, and our special guest will be Dr. Robin Geimer from Melbourne, Australia, and she'll also be talking more about different aspects of AMD, especially double layer sign, Sire sign, and we're just going to get the discussion on AMD a bit further. Well, until that episode, be well, take care, and I'll see you later.